I'm Stephen Crystal, Special Populations Core Lead. I'm very pleased to introduce the three professors presenting today. Dr. Soko Setoguchi is a professor at the RWJ Medical School and Rutgers School of Public Health and a leading pharmacoepidemiologist. Dr. Bonnie Chin is assistant professor at the RWJ Medical School and the Cancer Institute. And Jennifer Miles is an NJACS postdoctoral fellow at the School of Social Work, who is building an outstanding line of research in addiction health services research using large databases as well as mixed methods. So with that, let's turn directly over to Jennifer. Take it away.
Great. Well, thanks, Steve. And thanks everyone for joining. I'm very excited to present to you today with my co-presenters on a really important topic that I hope you will be excited about too. And let's see. Okay. So just quickly, I'll set the stage for the agenda for today. So first, I will go through a few slides to provide some context on what factors link the three presentations that we'll be giving. Then we'll go one by one into each specific research project that incorporates elements of environmental and community determinants of health. And then hopefully at the end, we'll have time for Q&A. All right. So first, let's set the stage, let's set the context. So what are environmental and community determinants of health and why do they matter? And I'm going to start with a quick poll. So in a moment, I'm going to launch a poll on your screen if you're at a computer. And the question is, how familiar are you with the concept social determinants of health? And so if you'd take a moment to respond. Great. All right, one more moment. Great, okay. So I'll share the results. So not surprisingly, most people who are coming today are pretty familiar with this concept, which is great. So let's see. And I think, Georgette, would you mind muting folks so there's no feedback? Okay, so you're pretty familiar with this concept, which is great. Another way of referring to the social determinants of health are upstream factors that have downstream consequences for our health. And so this figure depicts sort of the continuum that these upstream and downstream factors reside along. So all the way on the left-hand side of this figure, you can see social inequities or structural discrimination, which then feeds into the institutions that then govern the places where we live. If you were able to attend the NJACS Research Symposium a couple of weeks ago, one of the sessions that was hosted by the Community Engagement Corps had an excellent keynote speaker who really provided an excellent description of how structural racism influences our social determinants of health. So I'm not going to go very much into detail on these leftmost pieces of this figure, but it's important to keep in mind that these inequities are influencing our institutions, and that trickles down into the places that we live. And the presentations today are really going to focus on this middle box here, different features of the places where we live. So for example, Soko will be focusing her presentation on aspects of the physical environment. Bonnie will be focusing on aspects of the socioeconomic environment, and I'll be focusing on aspects of the healthcare service environment. But all of these pieces have consequences for both individual health behaviors, disease burden, and ultimately our length of life, and quality of life. But it's important to keep in mind that all of these pieces are nested within each other. And that's important both conceptually as well as analytically. And so this figure gives you a sense of what that nesting looks like. So at the outermost ring, we see that our economic and social resources are trickling down and influencing all of these other spheres of our daily life. So for example, a person who doesn't have as many economic resources might not be able to afford to live in a neighborhood that has all of the amenities that we would hope they could have access to. And so that might lead to employment that doesn't provide as many benefits. And so then their access to medical care services or generally the medical resources in that neighborhood might be low. We also know that conditions in our communities also influence our health behaviors. And so an example of that is in lower socioeconomic status neighborhoods, we see higher rates of alcohol outlet density. And because of that, we see consequently higher rates of risky alcohol behavior. And so it's important to keep in mind that these factors are both nested within each other and interrelate to one another. And analytically, we need to account for that nesting that can result in multicholinergic. But why is this important? So results from the Robert Wood Johnson Foundation County Health Rankings find that by and large, around 70% of factors that contribute to our health outcomes relate in some way to factors that are largely outside of the control of individuals. So these include things like our access to clinical care, our social and economic factors, as well as features of the physical environment. And we know that community resources are not distributed equally, let alone equitably. And this is particularly true for vulnerable populations, such as the ones that we'll be talking about today, including individuals with disabilities, folks with substance use disorder, marginalized and minoritized groups, as well as older adults. And so if we're really thinking about how to optimize our individual and population health, we need to be thinking beyond interventions that relate exclusively to individual level, maybe health behaviors. That's an important piece, but it's not going to get the full picture that we need to really have the best longevity and quality of life as we could otherwise. And so the presentations we will be showing you today, we'll start with my work that'll focus in on aspects of access to clinical care. Will be followed by Bonnie's presentation that's looking at the neighborhood environment and breast cancer. And finally, Soko will give a presentation that's looking at aspects of the physical environment, climate, and health outcomes among older adults with chronic diseases in the US. All right, so we understand now what are community environmental determinants of health. We understand why they're important. So how do we incorporate these within a research context? So the presentation I'll be giving is titled Racial and Ethnic Disparities in Access to Buprenorphine Among Medicare Disability Beneficiaries Who Have Opioid Use Disorder. And I just want to take a quick moment to thank everyone that is working on this project with me and also the funding that supports this work. So I'll give a quick background. Medicare beneficiaries who are younger than 65 years of age, and so they're eligible for Medicare because of a disability, are highly vulnerable to the influences of opioid use disorder. They have high rates of high dose opioid prescription fills, They have high rates of overdose, hospitalization, and fatal overdose. And compared to older Medicare beneficiaries, they have higher rates of diagnosed opioid use disorder. So they're a really important population to engage in treatment. And the most effective treatment for opioid use disorder is medication treatment. And so this includes methadone, buprenorphine, and naltrexone. But we know that despite the efficaciousness of these treatments, they're woefully underutilized. And this is true also of Medicare beneficiaries with OUD, where we see fewer than a third of whom are actually receiving buprenorphine, which is one of the medication treatments. We're also seeing racial and ethnic disparities in folks' access to buprenorphine. And so we're seeing that Black and Hispanic individuals are less likely to receive buprenorphine than their white counterparts. And while we're seeing overall increases in access to buprenorphine, the growth is slower for Black individuals compared to white folks. So, this is a really important problem. And what we don't know is what's happening within the Medicare disability population. Some of the factors that we see that might contribute to these disparities are features of the county and area level that might be related to the availability of the healthcare services, which in this case refers to buprenorphine prescribers. We're seeing the figures on the right are showing you that over time, we are seeing an increase in the number of counties where there's at least one prescriber, which in 2015, only 36% of counties in the US had at least one prescriber. That's about doubled to 2018. But there's still a pretty large swath of the country that doesn't even have at least one prescriber in the county. And we're seeing lower availability in counties that are rural, that have higher proportion of Black and Hispanic residents, with lower per capita income and with greater residential segregation. And we're seeing higher rates of prescriber availability in areas where there's a greater proportion of white residents that are urban in the Northeast region of the country. And some evidence that places with higher opioid overdose rates have greater availability, although there is some mixed evidence on that, and some research showing there's sort of a mismatch in community need with availability of prescribers. So when we're thinking about how to address these potential disparities, we want to be thinking, in addition to individual characteristics, what might be going on in the counties that might be dictating who has access to this vital treatment. And so the aims of this study were to first define whether we see racial and ethnic disparities in Medicare beneficiaries with disability, and to look at county level characteristics and examine whether they attenuate these disparities. And so just very quickly, I'll walk through the sample. So we had Medicare beneficiaries who are younger than 65 years old, and could be linked with the county level data sources that we're using. The sample folks were included if they had a new opioid use disorder diagnosis within this time frame. And the outcomes we were looking at for this analysis were buprenorphine prescribing within either 6 months or 180 days or 30 days of this new opioid use disorder episode. And we use multi-level logistic regression that accounts for county level clustering to examine these outcomes. And this is the part that I want to spend just a couple of minutes on, because I think one of the things I was excited about today was to hopefully provide some practical tips or tools for people who are interested in doing this research, but might not really know where to start. And so a big piece of this is understanding the data sources and how to link those data sources together to do this multi-level research. And so for this project, we relied on overall 3 different sources of data. At the individual level, we're using Medicare claims, all of parts A, B, and D, to identify folks who have an opioid use disorder, and then also whether or not they were prescribed buprenorphine. The red bullet points here indicate the geographic area locators that can be used to link with these other data sources. The county level data is coming primarily from 2 distinct sources. So the first source that provides information on buprenorphine prescriber availability in a county is coming from the Medicare Part D prescriber public use file. It's a little bit complicated for how to go from the information in that file to the Medicare claims. So as you can see, we had to use a variety of data sources to get to the county level identifier that then can be used to link with the Medicare claims. So there was a little bit of back and forth. We had to rely on a couple other data sources to eventually transform zip code identifiers to county level identifiers. And the public use file includes the NPI for every prescriber, and then also what they're prescribing. So we were only interested in including folks who were prescribing brand name or generic buprenorphine prescriptions to treat opioid use disorder. The area health resources file is providing us with a number of other county level characteristics. And so this is released annually by the Health Resources and Services Administration. Each release has more than 7,000 variables, so it's pretty enormous. And they're coming from more than 50 different data sources. And so what's really nice about this data source is a lot of these other places are really expensive. So for example, it includes variables from the American Medical Association physician file that normally are pretty expensive on their own. And it also includes data on, in addition to physician or medical service availability, information that's pulled in from the census and other sources that make it a lot easier when you're actually trying to do this research. The Area Health Resources file has a variable that's called the SSA code, and that is actually the state code and county code that's in the claims concatenated. And so to link the Area Health Resources file, you actually need to create a new variable in the claims that concatenates both the state and county codes, and then that provides the linkage between these data sources. I have links to these different sources of data in the slides, and I'm happy to share those slides if you want to know more information. Okay. So just quickly, quick description of our sample, folks who are included, primarily non-Hispanic white, 18% non-Hispanic Black, more than half were female. What's really troubling is how many folks were receiving an opioid prescription during their baseline period. So almost 3/4 of this group. And most folks were located in the southern region of the country, and by and large in urban metropolitan counties. All right, so our unadjusted outcomes, again, are receiving a buprenorphine prescription within either the first 6 months or the first 30 days. And so overall, we're seeing extremely low prescribing rates for everyone. Pretty dismal, fewer than 10% of people receiving this life-saving medication. But we're also seeing that even with these low rates overall, we're seeing that non-Hispanic white beneficiaries, almost twice as many are receiving buprenorphine compared to Black beneficiaries. And that's for both outcome measures. So just quickly, some results of our logistic regressions. For each outcome measure, we ran 2 distinct models. The first model just controlled for individual level characteristics, And then the second model layered in these county level characteristics to take a look at, what are the effects on the individual race ethnicity when you start layering in these county level characteristics. And so across the board, we're seeing very low odds for folks compared to non-Hispanic white beneficiaries of receiving timely access to buprenorphine. In most cases, adding the county level characteristics didn't have a huge impact, although we're seeing a slightly better performance once you do account for those county level characteristics. And we're actually seeing for American Indian and Alaskan Native beneficiaries that when we add in the community characteristics, we're seeing that significant p-value actually decline and become not significant. And then at the county level, the biggest pieces influencing access to buprenorphine were both the proportion of non-Hispanic white residents in a county, and then also buprenorphine prescribers. So we're seeing some important features related to both the availability of prescribers and influencing access, which is not surprising. And I'll close by sharing some limitations. And so we do see evidence that there are pre-existing disparities in who is actually diagnosed with an opioid use disorder, but because we're using claims, we don't really have a good sense of folks who are in need of a diagnosis, but then don't receive one. So we had to rely on Medicare prescriber information because we couldn't, we don't have information on the full array of prescribers in the US. So it might be undercounting the prescriber availability, although it's important to know, who's actually accepting Medicare to cover the costs. But some things we're looking into moving forward would be the importance of where people are receiving care, the site of care that might be influencing, in addition to county level characteristics, and that by and large, we need a focus on minority majority counties to really improve access. All right, so I will stop sharing and move on to Bonnie's presentation.
Thank you, Jennifer, for the great introduction and the presentation. So let me share my screen. So after Jennifer's presentation about the medical service environment, I will now talk about neighborhood environment with a focus on socioeconomic status and breast cancer. So my research program is to integrate multi-level and transdisciplinary components into cancer epidemiology research that will increase our understanding of multi-level modifiable factors affecting cancer health, particularly that I'm interested in the risk and the prognosis of breast and ovarian cancers. And with the goal to reduce cancer health disparities, my research has been focused on minority cancer populations. So in today's talk, I will focus on my studies to evaluate the role of neighborhood, social, and built environment factors in breast cancer among Black women. The studies I presented today are funded by the National Institute on Minority Health and Health Disparities through the K99R00 mechanism. So this figure is from the review paper by Dr. Gomez and other co-authors published in Cancer that illustrates how social and built environment could affect cancer continuum. The social environment is the socioeconomic composition of the resident population and the social aspects of neighborhoods. The potential pathways for social environment affecting cancer continuum include stress, social support, and health behaviors that are influenced by social norms. Prior studies have focused on individual level socioeconomic status as a major social determinant of more aggressive breast tumor phenotypes. The impact of neighborhood level SES on breast cancer was not well understood. Therefore, we conducted this study to fill the major literature gap, and the study was published early this year. A bit background of breast cancer. Breast cancer is the most common cancer among American women, if not including non-melanoma skin cancer, and the second leading cause of female cancer deaths. The current estimate is that breast cancer contributes to 30% of new cancer cases and 15% of total cancer deaths among American women in 2021. Breast cancer is a heterogeneous disease. Breast cancer cells may have the expression of estrogen receptor, progesterone receptor, and HER2, human epidermal growth factor receptor 2. If none of them is expressed, that is the triple negative breast cancer, which is the most aggressive breast cancer molecular subtype. The incidence rate of triple negative breast cancer among Black women is the highest in the US, which is about 2 times as the incidence rate among white women. Therefore, I'm particularly interested in understanding the risk factors for these more aggressive breast cancer subtypes among Black women. The aim of the study is to evaluate the association between neighborhood level socioeconomic status and breast cancer subtypes among Black women. In this study, breast cancer subtypes were classified into 3 mutually exclusive, clinically relevant subtypes, which are luminal A, HER2 positive, and triple negative breast cancer. The study is based on the Women's of Health follow-up study, which is a population-based study of Black breast cancer survivors in New Jersey, with detailed pre- and post-diagnosis data collected. We recruited women with recent diagnosis of breast cancer from 10 counties of New Jersey, as colored in orange on the New Jersey map here. For this study, we included 1,220 women diagnosed from 2005 to 2017 with invasive breast cancer. Data for tumor subtypes came from patients' pathology reports and cancer registry files. We considered individual level SES variables, BMI, and the reproductive factors in the analysis, and the individual level data were mainly collected during our home interviews. Participants' residential address at diagnosis were geocoded to latitude and longitude and spatially joined to census tracts. The neighborhood SES was characterized by the NCI's census tract level SES index. This is a time-dependent score using data from a series of American community surveys and constructed by factor analysis of 7 components. So education index at census tract level, percent unemployed, percent working class, median household income, percent below 150% of poverty line, median house value, and median rent. We got this index data from the NCI's census tract level SES and the rurality database. For those who are interested, I'm providing the link here, as well as the related references. The census tract level racial ethnic density was from 2010 census data. In addition to the census website, the EPOMS USA, which many of you might be very familiar with, also provides census data, and this is very user-friendly and is free. Now, let's look at the results. 58% of women had luminal A subtype, and 19% had HER2 positive, and 23% had triple negative breast cancer, consistent with other studies. Compared to luminal A, women diagnosed with other subtypes were younger and more likely to be premenopausal. And triple negative breast cancer cases were less likely to have obtained a college degree or above, and were more likely to have their first birth at younger ages. Previous studies have shown the reproductive risk factors may differ for estrogen receptor positive and negative breast cancer among Black women. Therefore, it's very important to take these individual level risk factors into consideration when evaluating the influence of neighborhood factors, which is a major strength of the study. The unadjusted comparison also suggested that triple negative breast cancer patients were more likely to reside in census tracts with lower neighborhood SES score. We grouped neighborhood SES index scores into tertile. T1 represents neighborhoods with low neighborhood SES scores, and T3 are the neighborhoods with the highest neighborhood SES. Using multi-level multinomial logistic regression models adjusting for relevant confounders, we found that lower neighborhood SES was associated with a higher relative risk of more aggressive forms of breast cancer. The association of lower neighborhood SES with higher relative risk of HER2 positive was marginally significant, with the relative risk ratio being 1.54, comparing the lowest versus the highest neighborhood SES. Lower neighborhood SES was also found to associate with a higher relative risk of triple-negative breast cancer. Compared to census tracts with high neighborhood SES, the relative risk ratios of triple-negative breast cancer subtype were 1.81 and 1.95 for participants living in areas with intermediate and lowest neighborhood SES, respectively. We also found that neighborhood ratio composition modified the association between neighborhood SES and triple-negative breast cancer. The figure here shows that Black women residing in socioeconomically disadvantaged neighborhoods, and particularly in areas with lower proportions of Black residents, have the highest risk of triple-negative breast cancer. In summary, our study supports that places people live may influence breast tumor biology. The pathways through which neighborhood socioeconomic features influence breast tumor biology were not evaluated in this particular study. But in vivo animal studies supported that there is a link between social environment and cancer outcomes. In epidemiological studies, we will need to integrate multi-level data, including neighborhood characteristics, individual level health-related factors, and biomarker data to better understand the pathways through which neighborhood features influence breast tumor biology. Now let's go back to this figure. Another important aspect of neighborhood environment is the built environment. Built environment comprises the man-made physical attributes of our surroundings, including structural conditions affecting walkability and the recreation, availability of health-promoting resources, and undesirable amenities, such as fast food restaurants. These built environment features play very important roles in individual health behaviors, such as physical activity and dietary quality, which further influence cancer risk and outcomes. We are currently studying the neighborhood built environment among Black breast cancer survivors in the Women's Circle of Health follow-up study. Our next steps include understanding the influence of both individual and neighborhood level factors on breast cancer survivorship issues, such as weight change after breast cancer diagnosis. In this slide, I listed some individual level and neighborhood level factors under study. The individual level factors include SES, menopausal status, lifestyle factors, comorbidities, and clinical factors that we collected through the Women's Circle of Health follow-up study. Through linking with other databases, as mentioned earlier, the neighborhood factors under consideration include the neighborhood SES, food environment, physical activity environment, as well as walkability of the neighborhoods. In addition, I'm particularly interested in understanding the potential altered pathways linking neighborhood environment to breast cancer outcomes. And our metabolomics data is just ready for analysis, which I think will help us to understand the potential biological mechanisms linking neighborhood environment to cancer outcomes. So my study has been supported by many great collaborators and students, and I would like to acknowledge their important contributions. Thank you, and I'm providing my contact information here. if you have any questions. And I will stop sharing. Here you go, Soko.
Okay, everybody seeing my slide?
Yes.
Yes.
Great, thank you. Good afternoon. So as Jennifer introduced, all of our sort of presentations really based on the conceptual framework that's presented at the beginning of the lecture or seminar here. So I'm going to be addressing environmental sort of a factor determinant. And if you remember, there was only 10% of the influence based on one study that it was showing how much influence that have. But the concern is though, because of the climate change, the influence of environment may be actually getting worse or more. And then this is clearly due to, this is from the International Intergovernmental Panel of Climate Change, showing that fact that the temperature is going up since pre-industrial era. And then it is due to the human activities, including burning oil, gas, deforestation, livestock farming, so on and so forth. And then the effect of climate change, not only globe is warming, and then there are more heat waves happening, there is more wildfire, more drought, more hurricanes, or severe weathers. Most recently, we experienced Aida and bad flooding and then casualties. So the higher the average temperature is, the longer the heat wave will be. So the projected change for 20-year period during which average global temperature increased by 1 to 2, 3.5, depending on what we're going to be doing in the next 20 years or 50 years, 100 years, it is going to get worse. The other thing that's going to get worse, we know, is air pollution, because the warming itself affect the air pollution, and air pollution also affect the temperature as well. And we all know that the impact of climate change on health is really actually happening on all around the health issues, not just heat-related hospitalization, but also mental health issues from severe weather, asthma, cardiovascular disease from air pollutions, changing the patterns of infectious disease, and a waterborne sort of disease, as well as much malnutrition from the high CO2 impacting the crop sort of nutrition. And then most recently, just yesterday, I believe that WHO also put out a report talking about a climate change and health impact. And again, as we were talking about, this is the sort of consequence of climate change. They called it a climate sensitive sort of illnesses or diseases outcomes. But there's also other sort of factors that affect the vulnerability or sensitivity to it. That's going to include structural environment, socioeconomic status, healthcare system sort of issues as well. So one of the, I'm going to skip this slide for the sake of, so one of the factors that this vulnerability, as I said, also a patient level factor or individual level factor include their health status, their age, so forth. And one of the factors that hasn't been examined is really the fact that many people on the planet are also on medications. This is really true if you're talking about older adults, because they not only get affected because they're older, but also because they have more comorbidities, but maybe because they also are on medications. We know that older adults account for 1/3 of medication use. And then they have, on top of it, because of aging, because of multiple comorbidities, they're kind of vulnerable to not only to the health impact of climate change or heat, but also side effects from the medications as well. So then question comes up, are there any drugs that are heat sensitive or climate sort of effect sensitive? And then there has been case report on various types of medications suggesting that there might be drugs kind of, or maybe on the causal pathway, that the drugs might be part of the sort of exacerbating factors. And when it comes to sort of heat related outcomes in older population. Then we sort of thought about, can the approach we take in pharmacoepidemiology, where we use large databases, can sort of be used to tackle this question, understanding the effect of medications, but also the climate on health outcomes. And one of my research themes being data linkage. So linking different sources of data, such as claims data to clinical registry, or claims data to electronic health record, or linking records within a database, such as mothers to babies. Then I was thinking maybe we can link the databases we use to understand the drug effect to area-based data on climate. So we came up with an idea to, I mean, people have done this, but mostly the data are linked prior to what we're started doing is linked to population level statistical data. But the goal here was to link area-based climate data to individual level patient data in Medicare or Medicaid. So zip code, through zip code, because we have a residence of zip code of residence in Medicare data or Medicaid data. If we can take air quality data or heat data, we will be able to link at the area sort of a level, zip code level, to Medicare data or Medicaid data or other national or international databases that have similar structures. As a proof of concept, we submitted a R21, NIH R21, and got funded to do this several years ago. And then this is a paper published out of the funding, looking at heat waves, medications, and heat-related hospitalization in older Medicare with chronic conditions. So the objective is, as I would been talking, to evaluate the short-term association of classes of commonly used medications with heat-related hospitalizations among older adults with serious chronic conditions. And then we used a self-control case series analysis and to address these questions, because we're only looking at the short-term exposure and then acute events. We took data source. Back then, I was at Duke University, and then have a different setup currently I have here. But we used two data, collaborating with climatologists. We took a data source. We used this data source to identify temperature at the zip code level, and then link to 5% Medicare data, like this. So Medicare data, temperature data, linked through zip code. Just quickly about what we found. This is just a distribution map we did, defining heat wave as a 95th percentile. And then we identified 37,700 patients, 100,000 patients with multiple chronic, what we call serious chronic diseases. These people have been hospitalized for these conditions before, so they are kind of at the high risk, severe chronic disease patient. And this is just a patient characteristics showing that the majority is actually female, mean age is close to 80, majority is white race, and then many people on these medications of interest that we had looked at in the study, except for stimulants, was very kind of rarely used in the older population. And then quickly results that we found that actually trying to look at the heat waves and drugs separately during the summer months. So it's only a summer period that we looked at. And then looking at the hospitalization, there seems to be effect on heat, but we also see, even though without heat waves, we kind of see some effect of drugs. And when they are combined, it tends to be higher, but not too much higher. And so the principal findings from here is effect of heat waves on heat-related hospitalization were similar to those found in previous studies. Older patients with comorbidity who experienced heat-related hospitalization were more likely to experience them during periods of medication use. And there's a kind of question came up during the study that medication increased susceptibility to heat stress from milder heat waves, because we only look at that kind of more severe heat wave defined as at least two consecutive days and then greater than 95th percentile. No strong evidence of excess risk on multiplicative scale in those who are exposed to both heat waves and medication. At the same time, we did not look at on the additive scale. And then that could actually have given us different answers here. So there are kind of many unanswered questions came up through this earlier study, understanding the heat outcome relationship as well as medication heat interactions. So I've kind of listed here what those are. And then we kind of applied for R01 that's got funded and now kind of currently going to understand heat, now air pollution, and medication use. So we wanted to understand heat, medication interaction in first aim in a kind of broader scale. Then second aim is understanding air pollution, medication interaction. And then third aim is really to understand the synergistic effect of all these three factors in the population. As I said, we wanted to look broader in terms of class of medications and also effect on air pollutions. Some of the medications have kind of synergy in terms of adverse events with air pollutions, and that's how we selected these drugs. And then we also looked for a better source in terms of temperature data, and then been collaborating with David Robinson at Rutgers, and he's a state climatologist, using this PRISM data that is kind of considering elevation regression for each digital elevation model. So it's not just the station data extrapolated into areas, but also taking into considerations and model gridded data. And then one sort of limitation we had in a prior study was that we were using two separate sources to look at the heat over study duration, and then we took care of that this study that we have one source throughout the study period. Heat exposure definition is another thing that we had had to think actually more carefully about before just saying that the 2 consecutive days greater than 95th percentile, because there are many ways to define heat exposure. And that's something we're currently exploring in the larger data set to understand what the most sensitive sort of way to identify heat exposure, and especially in this vulnerable population. And then also another thing briefly is about sort of how we link pay heat data to, or temperature level, area level data to Medicare data. As I said, we're going to link it through zip code, but we first have to go into the Medicare data to understand the sort of completeness of zip code information, potential accuracy of zip code information. So this is something we did at the beginning of the study, understanding what's available. Is there any missing? As you saw, there's really no missing. And but also people can change where they live. So we were looking to see if there's any change over time that gets reflected in the data, so on and so forth. So that's something we looked into here. It seems like a zip code is a reliable source, at least to identify where they live. And then of course there's the issue that the people don't stay in one place all day long. So that's another misclassification issues that we need to consider interpreting and conducting the study. How to link, again, another sort of issue that we didn't think deeper when we did the earlier study was that, zip code is actually a arbitrary area that could be big, could be small, depending on zip code. And how we link it to the climate data, that's kind of gridded data, either 4x4 kilometer or 10x10 kilometer, some area sort of gridded data, how we kind of correspond the large zip code area to that. And then one question is like, we would find a center. One sort of approach is we would find a center within a zip code, right? And then link it to the corresponding area, or we can weight that zip code area to the corresponding gridded data. And then when we do the center-based approach, how do we consider the area center versus population center? Because not all area in the zip code is lovable. So these things we really have to kind of think through and then decide when we are doing this current study. Just briefly about the air pollution. again, like we've been collaborating with a Harvard group who has developed model air pollution data. And that actually became very recently as a public source. So if you're interested in, I can send you the link to the public source. But the data, using that data, we modeled seasonal exposure to PM 2.5, as shown here on the figure. And then we're kind of looking at the effect of seasonal PM 2.5 on various health outcomes in our population. We are seeing many things being demonstrated in the past, and some things like vena thromboembolism is something that hasn't been looked at closely in the past. And then of course, the population we're focusing on is a chronic disease population, which didn't get much focus in the past. So that's something we're doing currently. Then extending this study to looking at the interaction between drugs such as steroid or other medications with air pollution is what we're currently doing. So the conclusion is area-based environmental data can be linked to large databases like Medicare data, Medicaid data to assess climate, health, and outcomes associations, and its interaction with treatment and other health risk factors. Multiple unique and non-unique challenges exist in weather, air pollution, health outcome studies. And then what we've been more and more realizing is really the interdisciplinary approach with careful considerations on study designs, analytic approaches, multitude of exploratory analysis, and extensive sensitivity analysis are needed to establish the optimal method to design, analyze each specific weather, air pollution, drug question, and interpret the results. Thank you. I'll stop sharing, Jennifer.
Excellent. Well, thank you everyone for these presentations. I think it's really showcasing how important and the more direct links we see between area level factors and consequences for health and health outcomes. Steve, I don't know if you want to take us home and summarize or start off questions.
I think we should give folks an opportunity for questions as much as possible in our 5 minutes. And Georgette, can people turn on their unmute themselves now if they like?
They sure can.
So in the interest of time, feel free to jump in, or if you're more comfortable, do the raise hand function. And we'll get some questions in. If we don't get any in a moment, we can certainly have some quick interaction among the panel. It's an extraordinary set of studies, and it's very impressive how much careful work had to go into all this. And I thought that Soko, your closing remarks were particularly significant and poignant as to how the sweating the details is really important, and getting the details right is very important. But ultimately, the power is tremendous. So
Did we have a question from Susan on?
Perfect. Okay, Susan.
Susan German.
Oh, can you hear me?
Yes.
I didn't realize that you knew I wanted to ask a question. This is for Bonnie. Did you compare the NCI census tract level time dependent index to, say, the Yoast index?
It's a great question. Although I didn't compare it myself, but the team that generating the NCI's census tract index compared with the Yoast index, and I believe they published in Cancer Causes Control several years ago, and they show that they're comparable, and for New Jersey.
Thank you. Okay.
One thing I want to say while others are thinking about their questions is that Jennifer has very graciously been sharing the technical work that she did with the linkage to actually the Harvard Socioeconomic Index, as well as the Area Health Resources file, and she did a very nice job of curating from among that massive set of variables. So those little technical tricks about what the linking variables are, she's indicated that she would be more than happy to share. We've already had one special populations consultation to share that. So that may be of interest into those. That, you know, each of these studies that has a little bit different design, there are different variables that may be important. And Jennifer is sharing some of it on in the chat. Jennifer, any comments on the commonalities among these presentations and the compare and contrast among them?
Sure. I think that what stood out to me first is that there's so many different ways of actually doing this research, and it all comes down to what are your research questions, and then what are the data sources available to answer those questions. So we heard myself talking about needing to identify a county linkage. We heard Bonnie talking about using zip code, and we also heard Soko talking about that. And there's also census tract. There's certainly you can extend upward to state or national levels. So all of that is a consideration for the work that you're doing. And we also saw across presentations that, you know, some of these environmental or community characteristics really make a difference. So, for example, both my presentation and Bonnie's saw that the racial composition of an area made a difference for the outcomes that we were interested in looking at. So that's sort of what jumps out to me. If Soko or Bonnie, is there anything else that jumps out to you?
Go ahead, Soko.
Go ahead, Bonnie.
No, I think that's a great summary, and I would be happy to answer any of the questions if you have. Just shoot me an email, and happy to share any materials if you're interested.
Yeah, I just want to comment that, you know, in old days, we were able to focus on just one thing and then try to understand one thing and then to health outcomes or something. But now I think we know the complexity of the environment and then how things interact, right? I think we're coming into the era, or we're already in that era of needing to consider other things happening to be able to understand what's happening of your interest, right? My case is drug and outcome, but drug and outcome is not everything because there are so many other things happening. And then I think that we're kind of different, but at the same time, we cannot really include everything in our model, right? So we're just kind of trying to pick out what's relevant in your study questions. And I think the approach that we're taking is quite similar, that we're kind of trying to come up with a conceptual model first, and then trying to pick out what the important determinants, and then try to gather information in various ways and then include in our analysis.
I think that's beautiful science, and just the idea of continually coming back to your conceptual model is so important, and finding that balance between what is tractable to do, what simplifications make the study tractable to do, versus taking account of a rapidly changing environment. For example, nobody even mentioned the fact that that there's been a pandemic interacting with all of these things over the last year and a half.
Yeah, the good thing is, Steve, that our data is not updated enough to consider that, because we usually have 2 years lag, right, in our large database world.
Soon.
Yeah, but soon we have to think about it.
We should talk
You're
about
right.
IQVIA data that we're hoping to get. You know, we're getting very close to New Jersey Medicaid data, are just about to the point where we'll have, in fact, we have 2020. So I think that's going to be an enormous source of complexity as well as exciting new science. So I just love how the three of you came together in this marvelous synergy, and I think, although it's tempting to continue, we probably should, in respect of everybody's time, should let everybody go, and thank our panelists, number one, for the wonderful presentations, and also for the expressions of willingness to share their methods, which is really important. So this is just absolutely marvelous, well attended, and so many thanks to each of you, to Georgette, and more to come. Check out this fall's star-studded remaining schedule of webinars. Thank you.
Thank you.
Thank you.
Bye. Thank you.